It's now time to undertake Chapter 3, Models of Abnormality. These refer to theoretical frameworks that we use to understand and explain mental illness. They can also be called vicariously approaches, perspectives, models, and even paradigms. And we'll use these terms just interchangeably. They guide how we see mental illness and the mentally ill, and how we go about trying to help and treat these conditions and these people. We'll start our explanation with the oldest model, that of the demonological model. It's safe to say that as long as there's been humans, there's been mental illness. And so the demonological reflects the views that humans first held. We'll have to consider whether or not any of these views are still held today. This view sees mental illness as being caused by supernatural forces. If that's your premise, then it would kind of make sense that you would go about treating mental illness with supernatural treatments, fighting fire with fire, if you will. Two of the treatments used would be exorcism and trephining. Now, exorcism varies from culture to culture and time period to time period, but always entails rituals designed to drive out the supernatural forces. They might be mild, such as prayer, chanting, maybe fasting. None of these harmful. But in other circumstances, they can be quite unpleasant, painful, or even potentially deadly. For example, forced vomiting with emetics, immersion in icy water, flailing, severe starvation, anything to make the body so uncomfortable that the inhabiting supernatural would be motivated to move on down the road and find a different host. We'll also consider, before we do that, let's consider exorcism. Is exorcism used today in the world? And the answer is a clear yes. Many cultures still have a demonological model viewpoint and do use these treatments. Even the Catholic Church, on special cases with permission, will use exorcism. Now let's consider, I should add that your HMO will not pay for exorcism. Now let's consider trephining. Did you learn about it in Intro Psych? If not, consider that small picture in the upper right. In trephining, a hole would be cut into the skull. You can see the person on the upper right hit the jackpot. You can see multiple holes. We have interpreted these holes to be an exit, an egress, to let out the supernatural. And you might say, well, why can't it get out the way it got in? Excellent question. I assume maybe it's like a lobster trap. The lobster can get in, but the lobster can't get out. So, and this isn't just one or two cultures. We have these skulls from all over the world. So this was a practice that was used to apparently treat mental illness. Some students get confused and they think the brain was being cut. No, absolutely not. While the person was awake, there would be no anesthetics at that point in history. The skull would be sliced open. A circular piece of skull would be removed. Who knows what they did with it? And you'd be sewn back up. Any head bump could be fatal. There's no skull protecting the brain. Could infections occur? Absolutely. Could people die of trauma? Absolutely. But still, people usually survive that. Experts that know bone can look at the edge of those skulls and tell if the edge of those incisions, those bone cuts, showed sign of healing, and they usually did. So clearly a highly unpleasant procedure, and probably would not be at all effective in terms of taking care of the condition at hand. We'd probably presume it would be a very severe condition, probably schizophrenia, and clearly after the condition was treated, the person would still have schizophrenia, but very likely a little PTSD on top of schizophrenia as well. Thank goodness no cultures in the world practice trephining anymore. So now let's consider the modern models of abnormality. These are all theoretical frameworks used by scientists, and you'll notice 4 blanks. See if you might want to guess what should go in those 4 blanks. it would correspond to our goals that we listed in an earlier chapter. Take a moment and see how you do. Who knows, it could appear on a future test. So the first blank would be a D. Was it define, diagnose, describe? Hopefully you went with describe. Second blank, explain or understand. Third blank, I know it has a P. It would be predict. And the fourth blank, a lot of choices. You could go with treat or change, modify, and of course abnormal behaviors. Listed are the perspectives that we'll be investigating. This slide's a particularly great slide to help you study. See if you can cover up the boxes and list them, order doesn't matter, by memory. And after you've done that, see if you can associate any names or concepts with each. If you can do this, you would be ready for the test when it comes to this subject matter. If you can't do that, I suggest that you need to do a lot of work to be prepared for the test. So again, a great study tool. I hope you use it in that manner. What are these modern models? Biological, which could also be called physiological, cognitive behavioral, psychodynamic, humanistic, with the related existential and Gestalt approaches, sociocultural, which includes both the family social and multicultural, and eclectic. For the biological model, we'll focus on the nervous system, specifically the central nervous system, and even more specifically the brain, and also the endocrine system, or in other words, our hormonal systems. Let's consider the basic unit of our nervous systems, the neuron. Take a look at the picture. Hopefully you recognize the neuron shown in green. Try to remember some of the name of the parts you learned in intro psych. Surrounding the neuron, you see the red cells called glial cells, which have many essential functions. We actually have more glial cells in our brains than neurons. Some of the glial cell functions include physically supporting the neuron, providing them with raw materials so the neurons can make neurotransmitters, eliminate dead and damaged and dying cells, and one I like to mention in intro psych, they make the myelin sheath of the neuron's axon. And there's other functions as well. So essential cells, even more numerous than the neuron. A major contributor to many, if not most, mental disorders are issues related to neurotransmitters. So it behooves us, don't you just love that word? It behooves us to know about the neuron in terms of its structure and function. So if you could, before we get into the actual lecture part of the slide, try to fill in the blanks at the top for terms, and then try to fill in the blanks with some of those terms on the bottom in terms of neuron function. So the first word, dendrites. Second, axon. Next, synapse. Next, soma, which you may or may not have learned in intro psych, S-O-M-A. Lastly, synaptic knobs. Next, let's review how neurons work. A certain part of the neuron receives chemicals, more formally called neurotransmitters. Hopefully you were tempted by dendrites. So they receive the chemicals, send the message down to the cell body. If they excite the neuron enough, electricity is made, which travels down the length of the axon, causing these neurotransmitters to be released, which can either excite or inhibit other nearby neurons. And these chemicals are released from the neuron's synaptic knobs. Now, you'll probably remember that as being kind of a complex process in intro psych. Fair enough, but remember, people that are taking biology courses will usually have to know much more, such as the polarity of the resting neuron, the ions that flow in, the ions that flow out, resting potentials, and so on. So this is actually a version which will hopefully be comfortable if you consider it, and I hope you will. Let's now consider some of these neurotransmitters. Dopamine, involved in many responses and conditions. We'll focus on two right now, schizophrenia and Parkinson's. In schizophrenia, we will learn that too much dopamine is being released, and the medications given for schizophrenia tend to correct this overproduction. Parkinson's, very different in nature. Parkinson's, the death is restricted to one little nucleus, very small area of the brain involved in movement. And these neurons are dying, and there is not sufficient dopamine for the person to engage in normal functioning. We'll consider both of these in much greater detail later on in the course. For now, just know that for schizophrenia, an excess of dopamine. For Parkinson's, cell death of dopamine-making neurons. Next, let's consider acetylcholine. As a mnemonic, maybe you think A for acetylcholine, A for Alzheimer's. In acetylcholine, there's massive neuron death across the brain, specifically the acetylcholine making and using neurons. We're not really sure of the causes. We know some protective factors, but we'll discuss this in much greater detail later on in the course. But for now, just associate the lack of acetylcholine with memory issues and with Alzheimer's. Next, let's consider GABA, the brain's major inhibitory neurotransmitter. And you might say, oh, thank goodness, one with a short name. Not so much. Its name is actually so long that we rarely use it full length. Gamma-aminobutyric acid, so we'll go with GABA. Again, it's the brain's major inhibitory chemical, so if it's released during the action potential process by a neuron, the neuron that receives it is less likely to communicate. So it inhibits neuron activity. And the lack of it is often associated with anxiety disorders. Again, we'll consider this chemical and, of course, anxiety disorders later in the course. We should also note that low levels of GABA are also associated with epilepsy. The last neurotransmitter we'll consider will be glutamate. It's the brain's major excitatory chemical. If it's released during the action potential process by one neuron, the neuron that receives it is likely to get excited, maybe even excited enough to have a neurotransmitter release of its own. In other words, an action potential of its own. And this would influence nearby neurons. It's also involved in anxiety, such as GABA, but in the opposite manner. GABA is the inhibitory one, so too little GABA could be a problem, while glutamate, the excitatory one, would have the opposite effects. Too much glutamate could be an issue, such as with some of the anxiety disorders. So they're both implicated, but opposite ways, basically. Of course, we'll learn more about glutamate and anxiety disorders later on in the course. Interestingly, very recent research is now implicating glutamate in depression in which it's highly resistant to treatment. So individuals with major depression who have taken various medications and engaged in therapy and still are not significantly better are termed treatment resistant, and we're finding that many of these cases involve the glutamate circuit as well as the two other ones we'll talk about in a moment. Let's now consider norepinephrine and serotonin together. Though we did mention norepinephrine earlier in the course as a endocrine gland secretion, in other words, a hormone, well, if it's outside the brain, it's considered to be a hormone. When it's released in the brain, it's considered to be a neurotransmitter, if that was confusing you. Let's consider two conditions which they're both very related to, mood disorders and anxiety disorders. And of course, we'll focus much more later on in the course. In intropsych, you probably learned about many brain structures, probably some of which are listed on this particular slide. It may relieve you or sadden you, I'm not really sure. Just so know that we won't really be focusing right now on particular brain structures, but we will look at the concept of a brain circuit. Modern abnormal psychology and study of mental illness often emphasizes the role of circuits interacting brain structures. So we'll learn some more about some of the major circuits involved in various conditions later on in the course. So we've considered the foundations of the biological or physiological approach, if you prefer. Next, we'll consider cognitive behavior model. Now, in the first box, you'll see a couple blanks. So in the first two blanks, look to the actual name of the model. It'll be very useful. And then for the last three blanks, think back to your learning chapter of Intro Psych and think of some of the major forms of learning that you learned about, and that would be your next blanks. So go ahead and do that, and we'll see how you did on it momentarily. So this approach draws upon learning principles to alter, well, let's see, the word cognitive refers to cognition. Cognition means thinking, so the first blank should be thinking, and second blank, just behavior. Based on, and what were some of those types of learning you learned about in Intro Psych? Well, classical conditioning, the Pavlovian type. You also learned operant conditioning using reinforcement and punishment. And I assume that you learned about social learning when a model is observed and imitated. So one blank should be classical or Pavlovian. A secondary blank should be operant, or perhaps you prefer the word instrumental. And the third blank, social learning, or sometimes we'll call it social cognitive learning. Theorists Aaron Beck and Albert Ellis are the standout. Their focus is on illogical thinking and maladaptive thinking. For example, some people believe that I ought to do this, and I ought to do that, and I must do that, and I must do that, and I should do this, and I shouldn't do that. Some of those are good. Yes, you should look before you cross the street. But must you always be perfect? Impossible. Must everybody like and love you? Impossible. Must you never make a mistake? Impossible. So they'll have you, in no small part, look at how you think and the contents of your thought. Apparently, Albert Ellis was a very interesting fellow. He liked colorful language, particularly the F-bomb. Anyway, I talked to one of his trainees, an older gentleman, at a psychology conference, and he told me a very colorful story that I'll share with you. When my colleague at the conference was under training of Ellis, his mother was visiting and was planning on attending a lecture given by his great mentor, the famous Albert Ellis. But Mom is not so fond of the four-letter word, so he asked his mentor and friend, would you please avoid the F-bombs? And he readily agreed, and he did. Nary a F-bomb during the entire presentation. Afterwards, this gentleman, this fellow, took his mother up to meet the great Albert Ellis. He greeted her very enthusiastically, and he said, you've got an effing great son, ma'am, and then the F-bomb started to fly. So at least he tried. Let's now look at some of the most used behavioral therapy techniques. This isn't a complete list, and we'll add a few more throughout the course. Many of them are useful in anxiety disorders, particularly phobias. So in flooding, if you agreed to it, you would be thrown into your worst fear. You're afraid of snakes? I'll take my 5-foot boa out of my aquarium. Afraid of rats? I'll take it out of the next aquarium. Take it out of spiders? Well, gee, I keep a tarantula just for that purpose. So you're thrown into your worst fear without any preparation. It's unpleasant, but you don't die. And you do it again, and it's still unpleasant, but you don't die. And the third time, it's not as unpleasant. And it gets less and less and less unpleasant to the point that you're neutral, could possibly even care less. Of course, you'd have to agree to this. It is drastic, but it's very quick, and if time's of the essence, maybe flooding would be for you. It would not be for me. It could also be imagined. For example, I don't think we want to put you on the edge of a building, but maybe with the virtual reality glasses, close enough. Next one, systematic desensitization. So we are going to systematically desensitize you. This has two components. First half will teach you full body relaxation techniques. You'll go through every muscle group in your body, clenching and relaxing, clenching and relaxing, so you can sit there and be thoroughly relaxed. And then we're going to have you construct a hierarchy, an ordering, a ranking of your fears. And you'll pair them one by one. For example, as you do your relaxation, you'll think about your, maybe if you have a plane phobia, just looking at a child's toy airplane. When you can be relaxed and still do that, well, if you look in the phone book under flight companies, TWA, United, and whatever, and when you can be totally relaxed, they will maybe have you drive past the exit that has airport on it. In reality, then we'll have you maybe drive in and out of the airport. Don't stop while doing your relaxation techniques. And then we'll have you sit in the parking lot for 10 minutes. And then we'll have you go to and watch planes take off and land. Again, all doing your relaxation techniques. You're not allowed to move on until you can be fully relaxed. At the end, you can actually think about it and be relaxed, or do it. Get on a plane and be relaxed, because you can't be afraid and totally relaxed at the same time. It takes longer than flooding. It's as effective, but it's far gentler. Which one would you prefer? For me, systematic desensitization all the way. For counter conditioning, let's consider Peter and the rabbit. Now, not the children's story, but an actual boy called Peter that was deathly afraid of rabbits. They used counter conditioning. They paired very skillfully the feared stimulus, the rabbit, with a pleasant stimulus. He loved ice cream. If they didn't do it skillfully, he could end up being afraid of ice cream. They paired it skillfully, and he lost his fear of rabbits. So first there's a large room, rabbit in a cage, far corner, he's eating ice cream, Peter's fine. Every day, the rabbit gets closer and closer in the cage, till one day the rabbit is sitting further back, but out on somebody's lap. Again, getting closer and closer. Now the rabbit is allowed to hop around the room, and closer, and then we'll actually move into the rabbit's right next to the boy on the lap, and then we're going to actually have the boy maybe have the rabbit brush his ankle to the rabbit, and by skillfully pairing, that is, the scary stimulus, the phobic stimulus, and the reinforcer, the phobia will be extinguished. Token economy, useful in so many populations. Hospitalized people with issues, children with intellectual disabilities, sometimes severe autism, sometimes ADD, or any child that's given you a run for the money. So you'll have to set up a system, a list of rules that you expect to be followed, and also goal behaviors. Every time the child reaches a goal behavior, putting the toys away without being asked, what have you, the child is given a token. The token has no value, but later on it can be traded in for something of value, such as a hug, a walk, a video game with a parent. So most of us can wait days, weeks, or years to get reinforcement. Consider your college degree. It's going to take you a while to get it, yes, but you're willing to wait. Other children and individuals cannot wait. They need immediate reinforcement to learn the behavior. So the child or the individual is given a token for every good behavior. Then as they acquire that behavior, you'll up it. Maybe they'll have to do 3 of those behaviors. Maybe they'll get 1 warning when they're messing up, and if they don't correct it, a token gets taken away. So very effective, and it is used extensively. Often you need to get everybody on the same game plan, so the teacher needs to use it, the baby teacher, the babysitter, the grandparents, the parents. But if it's being used consistently, it can be so effective. So with many conditions, part of the issue is the person lacks interpersonal skills. For example, trouble making eye contact, maybe advocating for themselves and doing that sort of issues. Conversations, just casual conversations. So these are all behaviors that can be taught and learned during therapy. So useful in so many conditions, from generalized anxiety disorder to just so many, and we'll look at this particular usefulness throughout the course. So response prevention is particularly useful for OCD, obsessive compulsive disorder. the person is prevented from doing the desired response, say hand washing. You dirty their hands and then you don't let them wash their hands for maybe 5 minutes. That's all they can stand. Then you let them wash your hands, and maybe next time it's 5 minutes again, then 5 minutes, then maybe 10 minutes, then 15 minutes. So you're blocking whatever the behavior is in their particular OCD constellation. And by blocking it, it's going to help to extinguish the connection and the need for that disruptive behavior. So do you recognize the great theorist on the right? Hopefully you know Sigmund Freud. And I do expect you to be able to spell his name correctly. It seems pretty reasonable given his importance to the course. The term for his therapy, it would be, you're tempted by psychodynamic. Not really, that's the model. His therapy, psychoanalysis. Literally, analysis of the psyche. In other words, of the mind. He proposed 3 forces shape personality. Take a moment, see if you can think of them. Id was one, ego, and superego. The focus of his therapy techniques, getting at the unconsciousness, getting at the unconscious mind. Let's now consider those 3 factors shaping personality, the 3 elements of mind. Id, we'll define it as irrational instinctual urges. Take a moment and see if you can think the 2 that Freud's theories emphasize the most. The sexual urge might have jumped out at you, that indeed is correct, but also the aggressive urge to harm others. The ego is the one structure that is focused in on reality, helping you with life's day-to-day decisions, reality as you live in it. It also tries to mediate between the irrational id and the irrational superego. Now their superego, I hope you have one. Freud felt that the sociopath does not. But the superego deals with morality, our conscience. So let's consider Freud's brand, Freud's version of therapy, psychoanalysis. Don't confuse it with the term psychotherapy. Psychotherapy is a general term. There's all forms of psychotherapy, Gestalt, existential, humanistic, cognitive behavioral. But when you use the term psychoanalysis, you're referring to a Freudian-based therapy. Let's consider 2 events that Freud discussed in terms of happening during therapy. One is resistance. Freud found that as he got closer and closer to the heart of the problem, the unconscious conflict, the patient would actively, though unconsciously, try to resist, forget appointments, change the subject, forgot that they were saying, get angry. In other words, throw roadblocks up on the process. So again, he saw resistance as a good thing, telling him he was on the right track. Next, let's consider transference and countertransference. Transference is when we'll use Freud's term, the patient unconsciously transfers their issues from somebody in their life onto their therapist, onto Freud. So maybe you became very afraid of Freud because you're very afraid of somebody in your life, maybe a parent. Became very angry because you're very angry to parent. Sexually flirtatious, perhaps. Again, transferring the issues from somebody in your life onto the therapist. Freud thought it was a good thing that would allow the person to work out those issues. Countertransfers, on the other hand, is a very bad thing. Want to guess what it is? If you're thinking when the therapist does that to the client, the patient, indeed you're correct, it's a very bad thing. The client is paying for services, so the last thing they need is to have the therapist dumping their issues on top of them. That's why virtually all therapists do therapy themselves, so they don't engage unknowingly in countertransference. Let's now consider 3 of Freud's techniques. One is free association. The client is supposed to say everything that enters their mind, no matter how off topic, rude, impolite, inconsequential, as quickly as they can. Freud thought that would basically bypass the normal filters and allow those unconscious conflicts to start sneaking out. Hypnosis, Freud used it extensively in his early days of therapy, but abandoned it, thinking that there are better ways to accomplish his goal. Dream interpretation, Freud wrote an entire book on dream interpretation called On the Interpretation of Dreams. So he thought this was a very useful tool to get at those unconscious conflicts. So again, Freudian therapy is always aimed at getting at those unconscious conflicts. When Freud considered personality, he thought it was started with the id. Its foundation was the id, instinctual, aggressive, and sexual instincts. Not a very flattering view of human nature. Well, the humanistic model is basically opposite, as we shall see. The two great theorists would be Abraham Maslow, pictured on top, and Carl Rogers, pictured on bottom. Emphasis would be, in part, fulfilling needs, and especially the peak of the hierarchy of needs. Take a moment and see if you can remember the peak step of that hierarchy of needs that you probably covered in intro psych and quite possibly a few other courses as well. So again, the name of the peak need. The peak need was self-actualization, the need to improve ourselves, to reach for our full potential. So they thought that was the driving force in humans, or at least it should be, to expand ourselves, to better ourselves. And in general, they had a very positive view of human nature, unlike Freud's emphasis of sexuality and aggression. One of the tools used by humanistic theorists would be unconditional positive regard. The therapist accepts the client without conditions, including all their faults. You might not like their faults, you might want to change their faults, but still you're positive and you accept them as a person. And maybe during that accepting climate, the client can dare to look at those things they don't like about themselves, maybe to discuss those things they don't like about themselves, allow themselves to start working on those things that they don't like about themselves. It all starts with the therapist's unconditional positive acceptance. Let's consider now two therapies which are considered to be offshoots from humanistic therapy, Gestalt and existential. Gestalt therapy recognizes that emotional issues are often at the core of mental health issues, and that many people have difficulty with emotions, accepting them, expressing them, embracing them. So the core of Gestalt therapy is embracing emotions. Maybe you've seen a snippet of a therapy in which the person is screaming and yelling and maybe hitting a pillow. Okay, that would be one version of Gestalt therapy. So again, strong emphasis on the emotional life of the client. Existential therapy, on the other hand, focus is trying to find meaning in life. Many times a person's life is going well in many areas, but there's something there's something troubling. And that would be up the existential therapist's alley to help the person identify what would make their life meaningful in their estimation, and to put them on that path to help them remove barriers that are getting in the way. So again, focus on a meaningful existence according to the particular person involved. Now let's consider the two major sociocultural models. Two perspectives within this approach: family social theory and multicultural theory. Family social obviously emphasizes the unit of the family, but also looking at factors such as social labels and roles, such as like husband, wife, intellectually disabled, mentally ill. So the effect of labeling on the individual. Also social connections, the strength of them, the weaknesses of them, the nature of them, having a profound impact on the individual. Also, the family structure and the communications. So, for example, has somebody been assigned the role of the failure, the family role of the provider, the agitator, and so on. Therapies will often be at the unit beyond the individual, or if it's individual therapy, looking at the role of the family, the person's groups, the couple, the community. So it could be solely couple therapy or family therapy or group therapy, but always at a recognition, even individual therapy, of these different groups' impact on the person's health and functioning. Now, multicultural theory looks at culture. Different cultures have different rules, different expectations. Race, in quotation marks, because I hope you know that race is a social concept, not a biological concept. Ethnicity, gender. So for a person's stress, it could be a role of maybe their labels placed on them from society, woman or a trans woman or a lesbian woman, have you, a Hispanic lesbian woman. You get the idea. So all these cultural factors can have a profound impact on the individual, and that is often explored and recognized in whether individual therapy or a wider sociocultural perspective. This slide will give you an opportunity to explore these concepts associated with the sociocultural models to make sure that you're comfortable in distinguishing the family social theory from the multicultural theory. So go ahead, work through each of them on your own, and then check on the answer. And this would be great practice for the test too. For JB, it is an example of the family social theory. For TJ, also primarily family social. IP, definitely multicultural. RW, definitely multicultural. For TR, family social. And QJ, the best answer would still be family social, since school involves school and work and the social connections they're in and family structure. So again, family social would be the best answer. And if you did well, great. If not, study the terms and then try again. Again, great preparation for your test eventually when it comes around. Let's lastly consider eclectic. If you know what the word eclectic means, it means diverse, varied. So a person that draws upon the eclectic model would be free to choose from amongst the various perspectives depending on the client's needs. So maybe dissociative identity disorder, in other words, multiple personality disorder, maybe they prefer a little bit of a psychoanalytic bent. For depression issues, maybe they prefer biological with cognitive behavioral therapy techniques, and so on. So eclectic draws from amongst all and can be very useful. So after you've studied the neurotransmitters, go ahead and do the slide without peeking. See what you know, and the ones that give you trouble, study those additionally, and it should serve you very well. So for gamma-amine butyric acid, in other words GABA, we know it is the major inhibitory neurotransmitter, and we associate with insufficient quantities of it with anxiety disorders. Norepinephrine and serotonin, we associate with mood and anxiety disorders. For acetylcholine, we said A is for acetylcholine, A is for Alzheimer's. When the neurons die and there's too low levels, it greatly impedes memory as well as the cognitive functions. Glutamate, the major excitatory neurotransmitter. We also associate with anxiety, but when you've got too much glutamate. Dopamine, you associate with schizophrenia once you have too much of it, and Parkinson's disease when a certain nucleus group are destroyed and die, insufficient dopamine. So again, if you did well, great. If not, just study the ones that gave you trouble and repeat as necessary. Again, great preparation for your first test. So unconditional positive regard, you should associate that with a humanistic approach of Rogers and Maslow. Combining multiple approaches, that certainly sounds pretty eclectic. Changing irrational thinking. Remember that cognition or cognitive means thinking, so that would be for the cognitive behavioral model. The client's role in their family. Well, that would definitely be the family social model. Accepting, then changing emotions sounds very Gestalt. Transference and countertransference definitely should associate with Freud, psychodynamic. Need for meaning in one's life, that would be existential. Role of neurotransmitters, that would definitely be biological. Free association and dream interpretation, that would be the second psychodynamic option. Free association and dream interpretation, also Freudian, also psychodynamic. And last, recognizing the effects of, for example, systemic racism, heteronormativity, that means assuming that everybody is heterosexual, and other discriminations, well, that would definitely be multicultural. If you did well, great. If not, keep practicing, especially emphasizing the ones you got wrong. If you aced the previous neurotransmitter activity, skip this, but if it gave you a little trouble, why not do it again? So for Alzheimer's, A is for Alzheimer's, A is for acetylcholine. Mood and anxiety disorders, that would be norepinephrine and serotonin. Major excitatory neurotransmitter, glutamate. Major inhibitory neurotransmitter, GABA. And Parkinson's and schizophrenia, either from too little dopamine in the case of Parkinson's, or too much in the case of schizophrenia. Again, if you had any trouble, study the ones that gave you an issue and try again.